Hi, this is Kevin Lyons. I'm the Executive Director of Rheumatology Nurses Society, and I'd like to welcome you to our next webinar, our current webinar today on challenging cases in rheumatology. We have our faculty with us today, immediate past president of the Rheumatology Nurses Society, Iris Zink. She's also the owner of one of the few NP nurse-run rheumatology clinics in the country up in Lansing, Michigan. And also Eileen Leiden, who is our chapter committee chair on our board. She is at NYU and a nurse practitioner there. Welcome, Iris and Eileen. I want to share just a couple of things of excitement that we have coming up. First off, I do encourage you to go to our website, rnsnurse.org, and look at our new dinner series that are coming up. We're doing 10 cities across the country. We're going to be in Dallas, Sedona, Phoenix. We're going to be in New York. We're going to be in Chicago and Seattle. It's going to be a great dinner series. These are accredited programs that are going out. There are 2 hours of ANCC accredited contact hours, and we are excited to have you join us. And that's a free dinner series that you're invited to. We also have our annual conference coming up in August in Dallas, Texas. We're going to be focusing on patients, and we're going to be focusing on advocacy and research. We encourage you to get into the early specials on that conference. So I'd like to thank GSK today. This program series, along with a couple of the issues of the rheumatology nurse practice surrounding lupus and SLE, was funded by a grant by GSK. So we thank you for them. So today we're going to be talking about, well, first off, I'm getting ahead of myself, Rheumatology Nurse Practice, the publication itself. If you do not receive this publication in the mail, please go to our website, rnsnurse.org, and you can sign up for free to receive this great publication. All the back issues of the publications are on the website, and there's also CE activities that are free to you as part of that. So our current publication is The Biologic Revolution in SLE, Why It Matters to Our Patients. We have many more rheumatology nurse practice, or we call them RNPs because rheumatology needs another acronym here in the future. So let's jump ahead and get started. Well, Iris and Eileen, thank you for your time today. Share with us about our case and our patient.
All right, so we're going to go over one of my cases today. So this is a 42-year-old African-American woman with a long history of lupus. It was diagnosed in her teenage years. I've actually taken care of this lady at my former clinic for about 13, 14 years before I moved to my new clinic. So this is the current presentation. So she's a 42 African-American woman, long history of lupus. She reports that when she was mowing lawns as a teenager, that's when her first lupus was diagnosed, because she had to go to the hospital because of the sun poisoning and issues that she had. So she had sun-induced symptoms that began when she was mowing a lawn as a teenager. She's had multiple previous hospitalizations for lupus flares with bleeding and thrombocytopenia. She actually had to have a blood transfusion when she was in high school because her platelets got so low and she got so anemic just from the sun exposure turning on her lupus. Socially, now she's a rare alcoholic drinker. She has 3 children, which are all grown now, and none still living at home. Her current medication list includes Wellbutrin. She also takes, and I always can't get this right, help me, Eileen, it's a Bexaban, but I say Eliquis, or what is it?
A Bixaban.
Which is that one Eliquis or is that Xarelto? I always get them confused, but she's on that, and she's on a little Lexapro, 20 milligrams, iron, gabapentin, lidoderm, prednisone, hydroxychloroquine, which she's still on 200 milligrams BID, and she takes Valtrex 1 gram daily for a history of recurrent shingles. So she had thrombocytopenia in high school, which was later diagnosed with as his antiphospholipid antibody syndrome. She developed lupus glomerular nephritis after her twins were born in 1991. And she had 5, almost 6. I was talking to the phone last night to Eileen. She had almost 6 years of IV Cytoxan before she was converted to Cellcept in 1996. And I had never seen anybody be on IV Cytoxan that long in my life. Her lupus nephritis was so devastating. She was a pharmacy technician. She was supporting her twins and her older daughter. And she was so very sick. She applied for disability multiple times, and she was denied, even though she was getting IV Cytoxan, which I could not believe. And then in 2000, her disability was finally granted. In 2004, her there was no more evidence of kidney progression. Her kidneys were finally quiescent. Everything with the lupus looked like it was doing pretty well. In 2008, we were able to wean her off all of her medications. You know, Celsep prior, she was only on hydroxychloroquine and prednisone 10 milligrams a day. Then, next slide. So in 2008, after she seemingly had been doing well, she was on Plaquenil, she's on 10 milligrams of prednisone. Her family had not had the opportunity to travel at all. They wanted to go back home to Mississippi to see some relatives. And I said, well, you know, lupus looks like it was really great. She got on an airplane. She flew to Mississippi. She was out in the yard playing with baseball with her boys, and she had a massive stroke, very massive. She was in the rehab for 6 weeks. She had to learn how to walk again, how to talk again. She still has aphasia, and cognitively, she's about 8 to 10 years old now. It was devastating. After her stroke, she didn't remember her children's names. She didn't remember a lot of her history at all. It was really devastating to her family. In 2010, after she's been through rehab and she's kind of, this is her new baseline, right? That she's cognitively impaired, but she still lives at home. Her husband takes really good care of her. Her adult children are, you know, they're in their late teens at that point in time. They're participating in her care. She was driving one of her children somewhere and she developed like visual loss, like complete visual loss, like suddenly everything's black. And so I was very concerned that she was having another stroke. We got her into Michigan State University Neurology Department, and they said that she was just having an optic spasm. So they put her on a calcium channel blocker, and that resolved her blindness issues. In 2012, because she was still having really heavy periods with her antiphospholipid antibody, she had a complete hysterectomy. In 2014, she was seeing hematology, and they decided to move her from Coumadin over to either Xarelto or you know, one of the other newer agents for bleeding and clotting. I had issue with that at that point in time because there was not a lot in the literature then about whether that was safe in people who'd had previous events, who had had antiphospholipid syndrome. And so I was worried even then, but, you know, we went with it. Hematology recommended it. So then I switched to my new practice in 2016, and she follows me over. She was currently off of her blood thinner completely when I saw her as a new patient at my practice. She came by herself. She drove herself. She's allowed to drive, even though she's cognitively impaired, which is crazy, but she's allowed to drive. So she came to my office after getting lost. One of my staff members actually met her in the neighborhood nearby my office and brought her the rest of the way because she kept calling because she was so lost. We got her to the office. Her husband's not with her. I used her cell phone. I called her husband. I'm going through her medication list, and I said, where is her blood thinner? And he said, well, the hematologist stopped prescribing it because the hematologist left town. We don't have a hematologist anymore. The primary care physician left town, so she just stopped taking the blood thinner. So that's where the case ends. So I want to talk a little bit about antiphospholipid syndrome, but I want to let Eileen explain that to you.
Yeah. Well, thanks for that, Iris. That's a tough case for sure. So yes, what is antiphospholipid syndrome? So it is an autoimmune disorder which the primary clinical manifestation is often thrombosis. It's when the immune system mistakenly produces anticardiolipin antibodies, and they act against some normal proteins in your blood. And this is what can cause your veins or your arteries to clot. And it can also cause some adverse pregnancy outcomes. Now, DVT is the most common thrombotic event, which can be associated, as we know, with pulmonary embolism. And then the most common site of arterial thrombosis is a stroke, such as what we have just seen in this case. It also can be, TIAs are also very common. And then the pregnancy complications that we can see are miscarriages or stillbirths. So it can occur independently, or it can occur in the setting of another autoimmune disease. So many other autoimmune diseases can be secondary, but the most common is lupus. In fact, about 50% of lupus patients have these cardiolipin antibodies, which elevate their risk of developing APS. They don't all get it, but many of them do have it. And the main treatment for patients with APS is lifelong anticoagulation.
So How often, so she's answered that question. Eileen's done a fabulous job of educating us. How often do we see patients with antiphospholipid syndrome? And I certainly, I have had so many young lupus patients that come into my clinic because I have such a heavy Medicaid population that have already had heart attacks and strokes. I had a young girl the other day, 26 years old, mixed racially, has had multiple children, and she came to me after having a stroke. She was 26 years old, and she's already had a stroke because of antiphospholipid syndrome. So, I see it fairly often. I had a lady last night that I saw that had antiphospholipid syndrome, and that was it. She doesn't have an autoimmune disease that we've been able to find yet, but she was found to have this by hematology after she developed a giant clot. So, I think it's something to screen for, certainly in our patients who have lupus that have had recurrent miscarriage. I always do it as a pre-screen when I'm doing my panel if anybody's had a miscarriage before. So the question that I wanted to ask the audience and Eileen is, what would you do in this case? Would you refill the patient's blood thinner?
Although it's tempting, I would not, because this is I can't say it now. Okay, which is a direct oral anticoagulant. Right now, there is, like you mentioned, Iris, there is lack of data demonstrating the efficacy and safety. But we do hope that in the future, with the study outcomes, that this does become a positive outcome, because for sure, they're more convenient for our patients than taking warfarin. I mean, we know it's so challenging to get our patients therapeutic. And also with this drug, our patient wouldn't need to go for lab monitoring, and they have a decreased risk of bleeding. But at this point in time, I wouldn't refill it.
So would you send her back to hematology for Coumadin, or what would you do?
Well, I would either do that or prescribe Coumadin myself. This is where I would collaborate with one of the attendings I work with as well. I know there's also some talk in strokes of adding an aspirin with Coumadin, when you have a stroke event as well. So that might be also something to consider. But I would probably feel comfortable doing it myself, but may also get some advice from the hematologist as well.
Which is what I did. I put her back on the blood thinner because I was part of this whole thing. I'm the one who told her family, yeah, go to Mississippi and we're going to wean down your prednisone to about 7 milligrams. And then she had this massive stroke. And even though cognitively we all know that we take care of these patients, and Monica Ritchie is forever telling us that bad things happen to lupus patients, you carry that around to a certain degree of, did I do something? Should have done something differently. She was not on a blood thinner before, but she had never had a thrombotic event. She'd had bleeding before, but she'd never had a thrombotic event before. So bad things happen to good people, for sure.
No, and I completely agree with the way you handle this case. I mean, she was in remission for such a long period of time. You weaned her down appropriately. There's nothing we know to do just because they have the cardiolipin antibodies. There's no evidence to show that we start them on aspirin. So this is the unfortunate, problem with this disease. We don't have guidelines, to do anything to prevent it, essentially. So I would have done exactly what you did.
And certainly, I think the problem with lupus is that we don't have the armamentarium to play with. We don't have as many drugs. I mean, it's a sneaky, vicious disease that can really affect the quality of life of our patients. And yet we're very limited. We're lucky to have been listed now. We have Plaquenil. We certainly have shared other drugs, but we're still not where we are with rheumatoid arthritis and psoriatic arthritis with the drug availability for this disease. And it's just complicated, and it certainly is devastating. So
absolutely. Yeah, that's also one thing I do. I enroll patients in this registry called APS Action, and this is because there are so many unanswered questions with this disease. Things like, we see patients who clot with low titers, like they don't even make the 40 cutoff. And, why is that? Why are there so many patients with these antibodies that don't clot at all? And why are there so many patients that we put them on proper anticoagulation and they still have recurrent events? So there's a lot more to learn, and we need a lot more maybe new drugs or just new guidelines and new tests, really, I think, to really properly understand, what's going to happen. And so what we do is we collect a lot of clinical information and tons of blood that gets saved for like 10 years or so. And it's an international study, so like 21 sites going on. So the hope is, 10 years plus from now, we'll have a lot more information. But with that said, hopefully we'll get some answers sooner than that. Don't get me wrong, but this is how long the registry is going on for. So I'm happy to be part of that.
Mm-hmm. That's super cool.
Yeah.
So, and you see that I've had her on Plaquenil BID, and that's, again, part of my fear. I ensure that she goes to the ophthalmologist, again, with the compliance issues with this patient and other things falling through the cracks. I do talk to her husband on the phone when she's in with her visits about the importance of getting her Plaquenil eye exams and stuff. So she, you can see the trend. She's been on for more than 10 years with a Plaquenil. So what do you think about that?
Well, I think it's great, personally. I would like to know first, though, what is her weight?
She's not any more thin. She's over 200 pounds. So I think she's like 220 or 230 and probably about 5'4".
Yeah. I mean, like, first off, as we know, lupus patients can do so well with Plaquenil, as long as these recommended guidelines are being followed. And some of the trials have even shown that it may reduce thrombotic events, which would be great for her, and also can maybe help reduce flare rates and organ damage and mortality. So there's tons of benefits for it. But yeah, what we are scared of course, is this retinal toxicity that can happen. And some of the most recent guidelines that came out say that it's safe if you give it, if there are it's 5 mg per kg of their actual body weight. So that would be perfect for her to be getting what she's getting, which is 200 milligrams twice a day. So that I feel comfortable with. And they ask that we just get baseline eye exam, and then you can wait 5 years if they don't have any other risk factors. And some other risk factors include renal disease, if they take tamoxifen, or if they have macular disease. Then the screening should be annually. And if there's any suspicion of retinopathy, you just have to come off, because these, initially, some of the initial findings actually may be reversible, but eventually you come to a point that they're actually not reversible. So it's extremely serious. So that's why it's good that they actually, are a little bit more conservative now than they were. It used to be, they used to allow us to give like 6.5 milligrams per kilogram, but now they've come down a bit. So, I feel good as long as we're following these guidelines to keep them on as long as we can.
I stumble when I'm teaching the patients. Like I say in the old days, because I've been at rheumatology for so long, that, we used to give the patients that grid that they put on their refrigerator that they looked at so to make sure the lines weren't wavy. But, of course we don't do that anymore. I tell patients they have Venetian blinds in their house. They should look at them if things get wavy. Or I tell them if they're having issues with color, like brown to black to blue, that it might be a red flag, that they need to see their ophthalmologist. How do you teach your patients what to look for?
Mm-hmm. I really ask them about their vision, essentially, is really the one question. I don't, those are good points that you're bringing up, but that, and I just ask them to go. No, but it's true. You want to have a little more conversations.
I don't know where those cool little grids were
Yeah.
that we used to get in the old days that we used to put on. But so many people have vertical and horizontal lines in their house that they can look at. If they get wonky, then you know that you might be in trouble. So from your perspective in New York, are your patients having any trouble getting their Plaquenil these days, or are you having trouble with that anymore or not?
Not anymore. I know that was an issue, about a year ago, but I haven't heard anything with it, and I haven't had any problems. How about yourself?
No. It's still expensive for some of my patients. They're really having trouble affording it. I still have a couple patients that might be getting it out of a neighboring country, but because of the cost, so they just can't do the $180, which is ridiculous for Plaquenil. And I just really feel like that's awful. And then that kind of makes us trend into other DMARDs when they can't afford it, because certainly they have to be on something.
Right. No, absolutely. I know there's a Canadian website and an Israeli website that one doc I know was using to get it last year. It's crazy. It really is.
All right. Do we have any other questions or comments? Oh, I wanted to do a shout out. Oh, great. So my student, Brittany Taylor, is watching live on the event, and so is my greyhound. I'm sorry about the nose in the screen here. And she's watching live. She is a doctoral student at Grand Valley State University who's got an interest in rheumatology, yay. And if you have the opportunity to mentor anyone, I would strongly encourage you. We need more rheumatology healthcare professionals. We know there's going to be a huge shortage. We're all passionate about our patients. That's why you tuned in today. And please, if you have the opportunity to mentor a student in nursing, whether it be a nursing student, nurse practitioner student, I have 2 nursing students who are at my office now. I've got them both working on projects about proving that nurse practitioner run clinics are viable and can be an option. So I've got that going. But if you have the opportunity to mentor out there, please do. It was only going to be helpful for the profession and for our patients down the road. Thank you so much for tuning in today. Anything else, Kevin?
Thank you both very, very much. A very interesting case, as always. Thank you, Eileen and Iris. And yes, Iris, absolutely workforce is a critical point with the Rheumatology Nurses Society, and we recognize not just the value, of course, of RNs, NPs, and PAs in practice, but also the demand that's going to be placed on them, both in recruitment and also practice efficiency, to deal with some of the demands coming forward with the workforce shortage. So thank you for embracing those students and bringing them into rheumatology and showing them the value. So thank you, everyone, for joining us. Our next broadcast is going to be on Wednesday, March 7th. And if you want to find out more information, of course, you can follow us on Facebook. We're on Instagram, Twitter. We have an entire calendar up on our website as well, which is rnsnurse.org/RMP. Remember, the dinner series is coming up. Sign up for the free copy of the Rheumatology Nurse Practice. It's great education coming your way. And then, of course, our annual conference coming up in August. So thank you again, Iris and Eileen. Any closing comments?
Thank you so much, Eileen, for helping me. I think these patients are so complicated, and being able to call you and Monica makes such a huge difference because it's complicated. Lupus is complicated, and we need to educate each other and help with our patients, and just being able to reach out to you is so meaningful to me. So thank you so much for joining me today.
No, likewise, it helps so much because it's a very tough disease.
Well, thank you all, and we will catch you on March 7th, if not sooner. Thank you and have a great day.
Thanks.
Thank you.